Neurocognitive and geriatric disorders involve problems with memory as well as difficulty with orientation to person, place and time, level of consciousness and other neurocognitive or thinking functions. These symptoms are caused by abnormalities in neural chemistry, structure or psychology originating in the brain or secondary to systematic illness. Patients with neurocognitive disorders may have psychiatric symptoms such as mood changes, anxiety, irritability, paranoia, and psychosis. The major neurocognitive disorders are delirium, dementia, and amnestic disorder. Many patients with neurocognitive disorders are elderly because normal aging is associated with minor neurocognitive changes such as a reduction in the ability to learn new things quickly and a general slowing of mental processes. It may be necessary for a physician to make the distinction between normal aging and a neurocognitive disorder in an individual patient. One important distinction between these two entities is that, in contrast to patients with neurocognitive disorders whose functioning is quite impaired, normally aging patients are able to care for themselves and carry on a normal life, particularly when elderly often show difficulties in concentration and decreased speed of mental processes. This presentation of depression is often called pseudo-dementia because it mimics neurocognitive impairment. As a branch of medicine, geriatrics is concerned with diagnosing and treating illnesses that occur in adults, generally over age 60. A subset of this geriatric neurology focuses on neurologic disorders common to this age group.
As a clinical psychologist, when you're working with older people who are aged 65 and over, you might often come across referrals of people experiencing some cognitive changes as they get older. Typically those cognitive changes will be in terms of memory functioning. As people get older, their memory does not work as well as it did when they were younger, and that's for normal aging. What can happen in cases of dementia is that the memory is working less well than other people of the age group over 65. And you'd know that it's not working as well because you would become more forgetful, and that's having more of a negative impact on your everyday life. In terms of what might be causing this, as you get older, some people can be more vulnerable to developing what they call a dementia. There are different types of dementia for older people. You can get dementia in young people as well, but it's more common in older people. The types of dementia you can get include Alzheimer's, which is the most common. You can get a frontal lobe disease, and you can get Parkinson's disease. You can get cognitive problems from stroke as well. There are different causes to the memory problem. As far as Alzheimer's goes, it's a degenerative disease and it's affecting how your brain is functioning, and the easiest way to explain it is in terms of you're getting more of the brain matter dying and degenerating, and that's affecting your cognitive ability, specifically memory. As a psychologist, when someone comes in complaining with memory problems, you would carry out some tests. They're called neurocognitive tests, neuropsychological tests, and you would assess how this person's thinking and cognitive abilities, their intellectual ability, is working for their age. You would do a set of standard tests, typically within an assessment battery called the WACE, and you check whether they can remember things as well as people of their own age group. You'd find that some of their cognitive thinking is not as flexible as it might have been when they were younger as well. It's not just memory. Someone might find it difficult to plan things in a way they used to find it easy. They might find driving more difficult. They can't remember their way around. They can't remember how to drive. They find themselves entering a room, for instance, and forgetting what they came there for, and that's normal. That can happen normally in adults, but it's something that happens more frequently as you begin to experience the early stages of a dementia.
Neurocognitive and the geriatric disorders, it's some sort of mental illness mental illness with psychological or behavioral classifications or manifestation associated with impaired in social and mental and emotional functions. We can find that the patient who suffering from neurocognitive and geriatric disorders suffering from deterioration at his memory and deterioration in his perception and deterioration in his orientation.
The development and course of the neurocognitive disorders might vary from individual to individual and from patient to patient. But usually the course is a slowly progressive one. If we took dementia, for example, we find the disorder develops slowly, usually or commonly unnoticed at first by the family, but later on the family tend to find that the individual with the neurocognitive disorder, dementia, might have memory problems.
Neurocognitive disorder. Neurocognitive disorder is the newest name in DSM-5 and the old name is dementia. Neurocognitive means inability or disturbance in cognitive and recalling and memory and intellectual function.
Patients with neurocognitive or geriatric disorders may include dementia, Alzheimer's disease, and delirium.
As regards the comorbidity of delirium and dementia, each disorder could be comorbid with each other at what is called beclouded dementia. Also, these disorders could be comorbid with other psychiatric disorders like depression and anxiety disorders, which increased the load of treatment and prescriptions for the patient and affect the prognosis and duration and the severity of cases. This comorbidity should be dealt with because it may affect the behavior of the patient and difficulty in managing his behavioral problems.
Delirium, acute onset. Acute onset suddenly appearing in personal, fluctuating course. The level of consciousness is impaired and characterized by or associated with the symptoms, hallucination or delusion, unreality and loss of insight. Hallucination means perception experience without external stimuli. And this disorder, the most common causes of this disorder is organic, means brain insult, infection, tumor, trauma, hemorrhage, stroke, and cardiac lesions, and metabolic lesions. These disorders must be hospitalized to evaluation or evaluate these patients.
Dementia is defined as progressive and usually irreversible global cognitive defect. Memory impairment are usually the first signs to be encountered, and such memory impairment is shortly followed by impairment of other domains. For example, dysphagia, agnosia, apraxia, and abnormal type of executive functions usually follows the memory impairment when we speak about dementia. Alzheimer subtype of dementia is probably the most common form of dementia and the most common cause of dementia. It is a degenerative disease, and such degenerative disease affect the most important parts of a client's lives. Memory, the executive functions are severely impaired. Usually the impairment in memory encounter the recent memory, but soonly the remote memory will follow, and it will be impaired and such impairment in memory is progressive. There is certain reversible causes of dementia. For example, the hematoma, for example, the hypothyroidism, vitamin B12 deficiency is considered to be a reversible cause of dementia. The symptoms is usually reversed when we treat such underlying condition.
As regards the epidemiology in delirium, it may constitute 0.4% of the population, but increased after the age of 55 to be 1.1 of this population, and increased more up to 10% in those above 85 years old.
Specific symptoms of major neurocognitive disorder. Evidence of significant cognitive decline from a previous level of performance in one or more cognitive domains, such as complex attention, executive function, learning, memory, language, perceptual, motor, or social cognition. This evidence should consist of concern of the individual and knowledgeable informant, such as a friend or family member, or the clinician, that there is been a significant decline in cognitive function, a substantial impairment in cognitive performance, preferably documented by standardized neuropsychological testing. If neuropsychological testing is not available, another type of qualified assessment. The cognitive deficits interfere with independence in everyday activities. The cognitive deficits do not occur exclusively in contexts of delirium and are not better explained by another mental disorder. Specify whether due to Alzheimer's disease, traumatic brain injury, substance medication use, HIV infection, prion disease, Parkinson's disease, another medical condition, multiple etiologies, unspecified. Correct diagnosis of neurologic disorders in older adults can be difficult because signs of disease may mimic normal signs of aging. Also, patients frequently have more than one neurologic problem at once. It can be challenging to find the best treatment once such a problem has been diagnosed. In addition to memory loss and dementia, as mentioned earlier, many neurologic disorders, weakness, numbness, poor balance, stroke, Parkinson's disease, become more common with age. Often more than one neurologic disorder are present at the same time.
Neurocognitive disorder and geriatric disorder, prevalence and epidemiology of this neurocognitive and geriatric disorder is 30%, above 65 years, and coming more in percentage above age 85. The most serious or the most common psychiatric or the most common geriatric disorder or the most common dementia in old age is Alzheimer's type.
The consequences of having a neurocognitive disorder is sometimes devastating to the family and to the patient. If we spoke about dementia, for example, it really has a strong negative impact to the whole family and to the patient. If we took the patient, for example, the patient themselves start to have mood disturbances. They might start to develop depressive symptoms. They might become depressed, which might complicate the problem even further for the psychiatrist or for the physician. They might develop certain psychotic symptoms. They start to have develop motor problems. They cannot walk like before. They cannot speak. They have speech problems. They have sleep problems. So the consequences of having a neurocognitive disorder, in this case dementia, is really very hard on the patient. As for the family themselves, they also might suffer from consequences their own, because they see their father or mother having this slowly progressive nasty illness, they start feeling sad for them. They themselves might feel depressed, and they have the burden of taking care of this individual. They want to take them to the doctor, they want to give them medication, they want to take care of them, and later on, when the disease is even worse, they might take them to the toilets themselves, change their clothes. So it's actually quite a burden to the family, and it has a negative impact on the family. So I think the psychiatrist and the psychologist and the social worker should also involve the family and try to support the family and help them, as well as the patient, to try to minimize the negative consequences of such disorders.
Alzheimer's disease, it's an important neurocognitive disorders. During Alzheimer's disease, we can find that the patient cannot identify himself. He cannot able to know the time, the place, the persons around him, even the most close person to him. I remember one of my patients, he cannot identify himself at the mirror. He cannot able to identify his face during the 4 phase of Alzheimer's disease. Alzheimer's also disease related to memory deterioration, a specific long-term memory. And we can also find that the patient has inappropriate speech during a communication with people around him. And you can find the patient distractible. Most of the time, he has blunted affect. He cannot express his affect or his emotions by his face expression. He has a poor expressive face.
The risk factors: normal aging, head injury, Parkinsonism, and Down syndrome are considered to be a risk factor for the development of such kind of conditions.
If we spoke about the risk factors of neurocognitive disorder, we'll find that most research in this area found that the biggest risk factor is old age. So the more the person increases in age or becomes older, the higher the risk of developing a neurocognitive disorder like dementia or even delirium. So one has to pay attention to that. Another risk factor is having multiple medical conditions, like for example heart problems, diabetes, and of course having a vascular disorder is one of the highest risk factors of developing a neurocognitive disorder like dementia. And there's actually a subtype of dementia called vascular dementia. So these risk factors should be taken into consideration. Other risk factors include smoking. Smoking has found to increase the risk of developing neurocognitive disorders. Regarding the prognosis, now the prognosis depends significantly on the underlying cause. For example, if we have an Alzheimer type of dementia, we know that the prognosis is actually poor, but might improve with medication. However, it is a steady course and the prognosis is actually clear.
Warning signs of dementia and neurologic disorders: misplacing things repeatedly, difficulty performing familiar tasks, poor or weaker judgment, personality changes, sudden weakness, difficulty walking because of shuffling steps or poor balance, loss of awareness. The prevalence of major neurocognitive disorder is difficult to assess, though it's safe to assume that it will closely follow the prevalence rates of the associated neurodegenerative diseases. Rates of major neurocognitive disorder increase sharply with age, with the most significant rise occurring in patients over the age of 60. It's estimated that approximately 1 to 2% of those aged 65 and older, and as much as 30% of those aged 85 and older, have been diagnosed with dementia, and therefore more than likely also meet the criteria for either minor or major neurocognitive disorder.
The main important assessment tools to make a clear diagnosis and significant diagnosis to patients who are suffering from neurocognitive disorders and geriatric disorders, it's dementia assessment scale and mini mental state examination. Mini mental state examination, it's some sort of assessment tools to identify how the patient can be oriented to time, place, personal, and events around him and situation around him.
The most common of them, delirium and dementia, which sometimes, not rarely, comorbid with each other in what is called beclouded dementia. As regards delirium, the main cause is central nervous system diseases and systemic diseases, and sometimes intoxication or withdrawal from pharmacological or toxic substances. As regards dementia, there is many types of dementia regarded as an etiology. Alzheimer's dementia, which resemble about 50% of dementias.
Perhaps neurocognitive disorders and geriatric disorders induce schizophrenia and induce also mood disorders, especially depressive episodes. Some of the patients who are suffering from Alzheimer's disease may induce and commit suicide or kill himself or deliberately self-harm himself without orientation that he can make some sort to hurt or cutting himself.
As regards the neurocognitive disorder etiology, we must mention the main neurocognitive disorders, which is delirium and dementia. It is the biggest categories in neurocognitive disorder. Delirium mostly caused by central nervous system disorders, systemic disorders, pharmacological or withdrawal or intoxication with pharmacological or toxic substances. As regards dementia, there is main types of dementia. The most commonly known types, Alzheimer's dementia. Alzheimer's dementia resembling about 50% of the types of dementia. Vascular dementia resembling about 25% of cases of dementia due to vascular etiology, infarction or hemorrhage in the brain. Combined Alzheimer and vascular dementia resembling about 10% of cases.
Diagnostic criteria concerning neurocognitive and geriatric disorders started by several factors, such as impairment in cognitive functions and mental deterioration, perhaps. We can find also that patients with neurocognitive disorders may suffering from deterioration at short-term memory, long-term memory, and attention deficit, and also there is impairment in his perception. Some sort of neurocognitive disorders may include aphasia. Aphasia, it means that the patient cannot recognize the object around him. Also, we can find that the main criteria in neurocognitive and geriatric disorders that there is clear impairment and significant in orientation. And orientation, it's include disorientation in time, place, personal, general evidence around him.
Dementia is a class or category of neurocognitive disorder, subdivided into Alzheimer type and frontotemporal type, and dementia due to Lewy bodies, dementia due to organic lesion, post-stroke dementias, characterized by all dementia, intellectual and social and memory and cognitive function are impaired. Dementia accounted for or estimated is 30% above age 65 to 85, and 47 above 85 years. Dementia can differentiate it from other neurocognitive disorder as depression, as delirium. As depression, the most common or prominent feature in depressive mood is depressive mood, loss of concentration, sense of suffocation, dysphoric mood, loss of interest. These symptoms may be associated with dementia, but the age may be different. And dementia can differentiate it from delirium. Delirium means acute fluctuating course. The consciousness is impaired in delirium, but in dementia not impaired.
We can assess neurocognitive disorders by using some sort of tools or many sort of tools to assess and evaluate the degree of neurocognitive disorders. The most one of them, or the most famous or common of them, the dementia assessment scale and mental state examination. You can also use mental state examination to identify the degree of dementia and the degree of Alzheimer, whether mild or moderate or severe.
Treatment of major neurocognitive disorder. While there are no direct treatments for major neurocognitive disorder or the dementia, it's typically associated with many of the comorbid diseases associated with major neurocognitive disorder have treatment options available. There is evidence that group-based cognitive remediation treatment in patients with major neurocognitive disorder and bipolar disorder may improve verbal memory, attention, executive function, and psychosocial function, indicating that this treatment option may be viable for patients whose diagnosis of major neurocognitive disorder is caused by other etiologies. In addition, there is significant evidence that the use of ATP-enhancing metabolic agents may improve cognitive function while possibly slowing the decline of the associated neurodegenerative disorder.
As far as treatment goes, most treatment for the condition these days is medical treatment. There are some drugs on the market and they can stabilize the condition. They can't cure it, but they can put off the condition deteriorating quickly. There are some behavioural techniques as well to help with memory functioning, and some behavioural techniques that you can use with your partner, with your family, to help you with memory and being able to carry on a reasonable level with your daily activities.
One of the major mistakes the family and sometimes the therapist have in dealing with learning difficulties or learning specific disorders, that they are mixing between learning difficulties, learning specific disorders, or the subnormality, and sometimes the pervasive developmental disorders. For that reason, the early diagnosis and the very specific diagnosis and looking for the comorbidity between these disorders is very important, and looking for the primary and the secondary disorders and what are the main symptoms here. What we are having is very important. The coloring of the society and the culture of these disorders and the way of the management in the society and the culture usually started before going to the therapist. Not only in the Arabic societies, but even the westernized societies. The reports coming and discussing these issues, they are investigating, looking for the spiritual causes. One of the issues happening in many countries, especially in the developing countries. For that reason, I have mentioned that many times in many programs and many episodes of this program, that understanding the difference between normal and abnormal child is very important. The issue, what's the normal improvement normal development per age, per year. How the normal development is very important to understand as a father or as a mother. And if you have any question or any query, please consult your psychiatrist. Go by phone consultation, not only just to go and have an appointment. Sometimes you don't have the time, don't have the money, just call and consult to be in the safe side.
Unfortunately, there is no a program of cognitive behavior therapy to make a significant treatment for patients who are suffering from Alzheimer's disease or neurocognitive disorders. But we can starting some sort of behavior modification program that make a schedule to start to write down the main important significant events at the daily routine life. To start to write also the year, the month, the day. To start to write also his age. To start to write also his name of family members, and to put some sort of photos to him or to him and his relationship with his family members. Another important thing that when you started to treat patient who's suffering from Alzheimer's disease, you have to let him the chance or the space to make any behavior. He can do it by himself, and you don't have to make him feel that he has helplessness and hopelessness, that he cannot able to do anything at all. So you have to help him by giving him an important and wild chance to make some sort of behavior that he can able to do it, and you are sure that he can successful to do it.